Hello, welcome, welcome. We're going to get started. I'd like to say welcome back to our live stream audience. Welcome back to the 2019 Metastatic LBBC Thriving Together Breast Cancer Conference. We are going to get started on our closing keynote presentation. This morning's session will feature Dr. Beth Popp presenting Living Well, Managing Symptoms and Side Effects. My name is Jamil Rivers, if you're not familiar with me already. And to the live stream audience, I am living with metastatic breast cancer. I'm a young advocate with LBBC, and I'm also a board member. And so I hope everyone has enjoyed this conference this weekend. I know that I have. I promise you, every time I attend an event, I learn something new, which is great for me. And I really think that LBBC is a key part as to why I'm doing so well. Let's see. So this morning's session will feature Dr. Beth Popp, who will present for the first 45 minutes, and then we will have approximately 30 minutes for your questions. We will be taking your questions via text, so please text your questions anytime during the program. The number is 610-365-7532. Dr. Beth Popp is an associate professor of palliative medicine at Brookdale Department of Geriatrics and Palliative Medicine, also with the Icahn School of Medicine at Mount Sinai. Dr. Popp has served as the physician leader, guiding the development of several teaching hospital programs, which provide hospital consultation services and ambulatory services to a range of patients at all stages of serious illnesses. Her clinical work has focused on management of pain and other symptoms in patients with cancer, communication skills for clinicians, customizing treatment plans to incorporate the unique values of patients, especially immigrants and patients from minority religious and cultures, medical ethics issues in palliative care, and palliative care needs of the developmentally disabled adult. Dr. Popp participates in public awareness activities about palliative care on behalf of the Center to Advance Palliative Care and getpalliativecare.org. CAPC's online resource for patients and families. The website focuses solely on providing information on palliative care from the point of diagnosis. Welcome, Dr. Popp.
Well, it's before noon, so I can still say good morning, right? Good morning. Both to those of you who are here in person and to those who are watching the live stream. I haven't done a lot of live streaming before, so this is a new experience for me. I just would like to add a little bit to the introduction to tell you a little bit about how I came to be doing this kind of work. My mentor, when I was a medical student, was a young breast cancer researcher. At the time he was young, I was even younger. He's now a past president of ASCO and a chair of a major academic department of hematology and oncology. And I became surprised that I was interested in working with people who had cancer. And what I learned from my experience working with him and learning from him is that I couldn't do everything. I couldn't be a really smart researcher and a really good clinician and have a life outside of work. So I had to pick 2 out of the 3. And I gave up doing research in the lab. And what I figured was that someday somebody really smart would figure out cure for breast cancer or other kinds of cancer. And I know that was the opening keynote. But in the meantime, there were lots of people who were living with cancer and wanted to live as best they could, despite the fact that this uninvited guest was intruding in their lives. And that was what really brought me to be interested in continuing to work with patients who had metastatic disease and advanced cancer, and really focusing on the symptoms of disease as well as the side effects of treatment that were related to that. So when I wound up connecting with LBBC and being asked to give this talk, I thought this is just perfect. This is really what I started my career to do and have really spent most of my career thus far doing. And it's such a wonderful opportunity to speak to people who are living that experience and have an opportunity to connect and to continue to find ways to help people live as best they can despite the fact that they have this disease. And I commented to Amy before, when I started doing this, and I've had already my 30th reunion from my medical school graduating class, this is not what a room full of breast cancer patients or breast cancer survivors looked like. People were not traveling around the country to come together and support one another. And it's really just a fabulous thing to have been able to witness this transition that all of you are benefiting from. And it's really a very exciting thing for me. So I'm really grateful to Living Beyond Breast Cancer for inviting me to speak and for all of you for being here. And I hope that I will give you some information that will help you continue to live well while you're living with metastatic breast cancer. If I can get this to listen to me, we'll move on. It doesn't seem to want to listen to me. Whoops, I got a little too zealous. So what we're gonna, okay, being flexible is part of the agenda for today. So what we're gonna do is really, I wanna make sure that everyone understands what palliative care is, and we pronounce it a little differently in New York, so we call it palliative care, and understand who can benefit from it, where it comes in for people like you or those who you are a caregiver for, because I know this is a mixed audience in terms of people who are living with the effects of metastatic breast cancer, whether those cancer cells, ooh, forgot about the mic, whether those cancer cells are living in your body or in the body of somebody who you love and care about. What are some of the symptoms and side effects of treatment that people frequently experience? And then I'll preempt some of the questions with the questions that most often come up, and then we'll have time for additional questions at the end. So let's start out with really the most basic question, which is what is palliative care? And that's something that about which there are often a lot of misconceptions and misinformations. And I think it's really important to start out making sure we all understand the same meaning of the word, since it's what we're going to be talking about for much of the next 35 or 40 minutes. So palliative care is specialized medical care for people who are living with a serious illness. And that specialized care focuses on relief of the symptoms and the side effects and the stressors that come with having a serious illness. And I can't imagine there's anybody in this room who wouldn't count metastatic breast cancer as meeting the definition of a serious illness. If there is, we'll talk about that later. We might need to do a little reality check, because I've never met anybody who didn't think being told they had metastatic breast cancer or that somebody that they loved had metastatic cancer was a serious illness. The goal is really focusing on quality of life, both for the patient and their loved ones, because everybody in this room knows that the person who has the cancer cells in them is not the only person who's affected by the cancer. And sometimes it took clinicians and specialists a lot longer to realize that than the people who were living with disease. But I think we've begun to catch up about that. Palliative care is delivered by specially trained interdisciplinary teams, and that's one of the places where it may be different depending on what kind of a setting you're getting cancer care in, that it may be different than other aspects of your cancer care. Palliative care really focuses on use of the entire interdisciplinary team. So physicians, nurses, social workers, chaplains, creative arts therapists, physical therapists, all kinds of different health professionals who come together to work on this challenge of helping people feel as best they can and alleviate symptoms of disease and side effects of treatment, because we're dealing with people who are often going to be having treatment, if not consistently through the remainder of their life, often on for significant intervals through the remainder of their lives. One of the things that's really important to recognize about palliative care, and it's one of the misconceptions that I want to make sure I erase from people's minds quickly, is that palliative care is appropriate at any age. We take care of, I don't take care of children because I'm not a pediatric palliative care specialist, but such people exist. And it really has nothing to do with age. It's not only for people who are older or people who only have very advanced or treatment refractory disease. It is appropriate for people who have significant symptoms. Did I lose my sound? People who, thank you, who have significant symptom burden, either from disease or from treatment at any point in the course of their illness. And the degree to which people may need palliative care can ebb and flow or wax and wane throughout the course of illness. And the other thing that is really important to stress is that palliative care is not an either-or with disease-directed therapy. So palliative care can be given together with disease-directed therapy, and that's primarily what I do in terms of my own clinical practice. I am embedded in a cancer treatment center that's part of an academic medical center, and I treat the symptoms and side effects of treatment together with a medical oncology, surgical oncology, radiation oncology colleagues who are focusing more on the disease-specific aspects of therapy. It's not me or them, it's all of us together. So again, I don't have to tell this audience because your experience is part of what has informed what we do clinically in the field of palliative medicine and palliative care, is that paying attention to those symptoms of disease and treatment-related side effects is every bit as important as making sure tumors get smaller or don't grow bigger. And making sure that we can enjoy the lives that we are living while this disease is in our life is a very important part. It's not only about making the disease go away or to slow down, irrespective of the cost in other aspects of our life. It's finding that really crucial balance. And that's really not rocket science. We want to we would love to make the disease go away. I don't think there's anybody in this room who wouldn't love to have their disease vanish from their life. We would love to be able, as physicians and nurses and oncologists and all the specialties, would love to be able to do that. It's not where we are on April 7th, 2019. We'd all love to get there. In the meantime, we want to make it go away and stay away for as long as we can. We want to make sure it doesn't grow any faster than we can keep it from doing. And we want to make it have less of an impact on you doing the things that matter to you and doing the things that are important to you as you live your lives. And that's really what we talk about when we talk about maintaining good function and quality of life. We want you to help you have your care sort of connected and coordinated. There are a million white coats and scrubs and people with, medical name tags and different specialties who are coming in and out of your treatment rooms and your lives and your appointments. And sometimes you wonder sort of why they're all in silos and nobody's talking to each other, and why do you have to answer the same question 17 times or 23 times? So we really want to help coordinate that care, and that's often what we wind up doing, is kind of helping to pull things together and get everybody on the same page. And that's the page that you've written, and you've written with what your values and your goals for going through life with cancer is. And making sure that you have the support to make informed decisions about critical decision points and critical times when your treatment may need to change. So that's what palliative care is. And where does it come in? Well, believe it or not, the oncologist said already a few years ago, every patient with advanced cancer, so every patient with metastatic disease, whether they are getting care inpatient in the hospital or outpatient in an ambulatory setting or an office setting, should receive dedicated palliative care services early in the disease course, the same time they're getting disease-directed treatment. I would imagine very few of you have had the opportunity to receive palliative care services in accordance with ASCO's clinical practice guideline and what's really the aspirational best practice in the field, because the field is small. It was only recognized as a specialty in 2008. The first board exam was given in 2012. So it's really not been recognized so long, although, as you heard, some of us have been doing it longer than that. And the field was growing out of people who were in oncology and recognizing that these things were important. So the workforce of specialists is still small and really started out in the inpatient setting. So most of you get your treatments, if you're like most patients with metastatic breast cancer, in an outpatient setting. And that's been kind of the second wave of access to palliative care services. But that's where we're trying to get to. And when patients were asked, people were asked in the community, just adults, not patients, I misspoke, whether they thought what they knew and whether they were knowledgeable about palliative care, most people didn't know. It wasn't a term that people were familiar with. Once they were told what palliative care was, it was like mom and apple pie. Everybody wanted it. I mean, who wouldn't want care to be well coordinated, focused on what mattered to you, and to help you feel better while you were living with a disease that might not be able to be made to go away forever? I can't imagine. I'm surprised that the number wasn't 100, to be very honest. And it's not a surprise that that's what people want. If you talk to people who are living with any kind of a serious illness, those are the things that matter to them. So how does that narrow down from all people with a serious illness to the focus that you have here, which are people who are living with metastatic breast cancer? So again, I don't have to tell you, there are lots of symptoms of disease, and there are lots of side effects related to treatment that come together. I tend to think of those things as symptoms, whether they're caused by disease or caused by treatment. I know that not everybody thinks of all of those things as symptoms, and sometimes they will think separately about side effects from treatment. So if I slip and refer to all of them as side effects, I want you to realize the way that I'm using the word so that it's understood clearly by all of you. And we have so many new treatments which are in many ways less toxic, less side effects than we often think of them as being less side effects. But I think really it's more that they're different side effects. So we used to think lots about hair loss as the major side effect of any kind of cancer treatment. We have lots of drugs now and treatments that don't necessarily cause hair loss, at least not total hair loss. But we have lots of medications that cause peripheral neuropathy, or they might cause hair to be thinning, or they might change the way your muscle and body fat is distributed in your body, or it might cause issues with breathing. There are just a whole different spectrum of side effects, especially as we've moved from the traditional, what we call cytotoxic chemotherapy, the drugs which directly kill a cancer cell, to things like immunotherapy and targeted therapies, which treat cancer using the body's immune system or by targeting specific molecular targets in the cancer cells. And so we really need to make sure that we continue to have a good understanding of what are the side effects of these treatments so that we can use the best possible balance of treatments that are going to decrease the symptoms that the tumors are causing and balanced against any side effects that the treatments may cause. And I think one of the things that it was very timely, and I just have to show this all to you. So this is a page out of my New England Journal of Medicine that came this week. I was going to make a screenshot of it and add it to my slides, but I didn't want to stress. It comes on Thursday, and I know this conference was starting on Friday, and I didn't think that was fair to the staff who were working really hard to put together a wonderful conference for you. But the title of this is Time to Study Metastatic Cancer, as a hyphenated term, Survivorship. And it was a lead perspectives piece, so that's an opinion piece in the New England Journal of Medicine, which is really one of the major general medical journals in the country. And it was written by a colleague of mine who is also a medical oncologist and palliative care physician, and a colleague of his who is a health services researcher. Both of them work in a major academic medical center on the East Coast, and both of them are working and living with metastatic cancers. I've seen this, the author who's a physician, at conferences recently. I had no idea he was living with metastatic cancer. And the two of them wrote in an incredibly eloquent fashion about all of the issues that they face as people living with metastatic cancer, and how limited their clinicians' knowledge has been to help them and guide them through this. And it's really a call, a very loud call from a very high rooftop for more attention to be paid to research in this area, understanding what the experiences are like, and putting the research money into effective ways to treat the symptoms and side effects of disease, because we now have cohorts of patients who are living for 10, 15, 20, 30 years with metastatic disease through all of that time. Many of those symptoms and side effects are physical, but some of them are emotional and psychological. And it is a whole set of issues that we need to learn how to support people, patients, their families, their loved ones, through the experience of living long-term with these aspects of illness and treatment in their lives. And it's a new questions in terms of the research questions. They're questions that 30 years ago when I was in medical school, we hoped we'd have to ask. And now we are at the point where we need to ask them. We probably needed to ask them already 10 or 15 years ago, but everyone's recognizing that now. So let's talk for a few minutes about what some of those symptoms are. I doubt I'm going to tell you anything you don't know or somebody at your table doesn't know or hasn't experienced. And one of the things that you'll see is that many of these, it sort of reminds me of when you used to make cards and build buildings out of cards. Everything's sort of related to one another, and it all balances, and they're all sort of interdependent on each other. So the first thing that most people think about is pain related to cancer, and pain can be a very important symptom. For many people early on in the course of disease, pain is what lets them know they have a problem. And then as their disease-directed therapies work, the pain gets better, and they may have other symptoms instead. One of the things that's a very important issue now is that opioids, or medicines in the chemical family related to morphine and codeine, have traditionally, and since the 70s, been the mainstay of treating cancer pain. And as we have people who are living for decades with metastatic disease and with pain related to their cancer or their cancer treatment, we've come to recognize that it may not be such a good idea for patients to be on these medicines for the long term, for when the long term is decades. And that's both because of the impact on the patient themselves. There are effects on the hormonal axis that can come from long-term opioid use on the GI tract, as well as physiological changes related to pain perception. And we also have a huge problem related to opioids, medicines in this family, being out in the community. And many of you, I don't know how much of a problem it is here in Philadelphia. I know many of you have come from other parts of the country. There are places in the country where this is an enormous problem. And both for the patients themselves and for our communities, we've come to realize that we need to think differently about the role of opioids in patients who have cancer pain long term. And we are both looking from a research standpoint for other kinds of medicines that we can use effectively, and also recognizing that often what we need to do is not a pill. It is utilizing the kinds of treatments that don't necessarily involve exchanging an opioid medication for another kind of medication, that we need to look at things that are not necessarily medication-directed therapies, whether those are things like physical therapy or exercise, or whether those are cognitive and behavioral therapies and other kinds of ways that we can utilize our brains to change the way we interpret a pain message that's coming in and focus on function rather than necessarily a pain score. And for those of you who are not new to life with metastatic breast cancer and for whom pain may have been a problem, you may find your clinicians' attitudes about continuing opioids changing. And I think it's important to put that in a context that may or may not have something to do with how you're personally doing, but about our broader understanding about what's helpful for people in the long term. Peripheral neuropathy is a very specific kind of pain, and I think it's something that is very predominant in patients with metastatic breast cancer, in large part because of some of the medications which are most effective in treating metastatic breast cancer from our older group of medicines, the cytotoxic chemotherapy drugs, in particular medicines in the taxane family, so Taxol, paclitaxel, Taxotere. And that is a syndrome where the nerves basically send a message that they ought not to be sending, that people have numbness, tingling, and often the sensation like your limbs are falling asleep, only you haven't been sitting with your legs crossed so that your foot should fall asleep, or you can't feel where your feet are as you're walking. And sometimes it can be significant enough from some chemotherapy medications where people will have difficulty. I've had patients who are men who are used to having to wear button front shirts all the time, and they can't dress themselves because they can't feel where the buttons are. And we're not used to having to look at where the buttons are. And sometimes they can learn how to do these things, but I've also had professional musicians. You can't be a violinist if your hands are numb. So these things can have tremendous impact on people. They can be a nuisance or they can really be disabling. This is a somewhat unique type of pain. It doesn't respond well to the opioids, the medicines I was talking about before. And many times the kinds of medicines that we use to treat this to a reasonably effective amount are medicines that didn't come on the market originally to treat pain. Some of these medicines do now have FDA approval for treating neuropathy. Many of them don't have FDA approval, though, for treating neuropathy in breast cancer or any other kind of cancer. There are other chronic illnesses, most commonly diabetes, that tends to cause a similar kind of neuropathy. And one of the things that can be very challenging about that, one is when one is engaged in their healthcare and does their own research, you sort of look and say, well, why am I being given this medicine? It's an antidepressant or it's an anti-seizure medicine. I don't have depression and I don't have seizures. Or with the way healthcare utilization is being addressed in the insurance companies, it can be difficult to get the medication covered if it's not being administered for exactly the reason that the company has gotten approval from the FDA, the government regulating agency, for. So those things can be very challenging when we try to help treat neuropathy effectively. The treatment which I think is getting the most attention and where I get a huge number of questions, and I wish I had answers, but we don't, is the role of CBD and medical marijuana. How many of you live in states where medical marijuana is obtainable? So a pretty significant number. And researchers can't do the research because of the way there are regulations around marijuana. So the honest answer is, I don't know. CBD, which is, just very quickly, marijuana, the plant has two primary chemicals in it that we've been able to identify, CBD or cannabidiol and THC or tetrahydrocannabinoid. CBD is more effective for pain THC is more effective for appetite stimulation. Those are sort of the two indications in most states related to medical marijuana. In many places, you can buy CBD oil in a health food store, but it doesn't have the same quality controls because health food store supplements are not regulated in the same way that pharmaceuticals are, and the research hasn't been done. So there are certainly, I've had many patients tell me that this has been invaluably helpful to them, but I've also had patients tell me that they felt like they were throwing their money away, and nobody knows because we just haven't been able to do the research studies, and I think would be a tremendous service to patients if we could figure out how to address the policy issues and legitimate concerns about abuse and diversion and concerns about substance use disorder so that we could get help for the people who can. We figured out how to do it with other medications that were dangerous, like thalidomide, but we haven't been able to figure out how to do it with regard to marijuana. So I'll stop editorializing. Hot flashes are a huge issue which are relatively unique to the metastatic breast cancer population and men with prostate cancer. Venlafaxine, which is again one of these medications that came on the market for a completely other use, it's an antidepressant medication, has been shown to be very impressive in helping with hot flashes. But you can't take venlafaxine or other medicines in that class together with tamoxifen, which is a drug that's very commonly used in treating metastatic breast cancer. So there's a whole group of patients who are likely to have this drug treatment-related side effect who can't get the best help we know to ameliorate that side effect. And these hot flashes can be extremely disabling to women with breast cancer, men with prostate cancer who are experiencing them. Gabapentin, which is a medicine that originally came on the market to treat seizures and is used for a variety of other symptoms, is actually may be of some value also. The research is, in my opinion, a little bit less clear. But again, it's a not expensive medicine, so we tend to be able to get it for patients who can have a try to see if it will be helpful, and it tends to be a medicine that is well tolerated, but we're using it what's called off-label, so in a way that it was not approved for by the FDA. And this is where sort of the cycle of related symptoms starts coming together more. Hot flashes can be an enormous impact on sleep disturbance. And sleep disturbance affects concentration, and sleep disturbance affects ability to tolerate pain. And we start to see all of these symptoms kind of build on one another and create a cycle that we don't always know how to interrupt. So let's talk for a minute about sleep disturbances. As I said, they're often interrelated to issues with mood, issues with pain, or other medications can simply alter the sleep-wake cycle or the amount of REM or restorative sleep that people have as they go through the night. A lot of this can be done with what we call sleep hygiene or behavioral interventions. So that's thinking about what's happening in your life in the time before you go to sleep. Are you having exposure to screens? Are you having exposure to things that are sort of stimulating and making you be more awake and alert? The issues about blue light that comes from our electronic device screens, whether it's a television or a tablet or a phone, can be significant, and people are often starting to use apps that alter the blue light frequencies, filters, or glasses, even if they don't need vision correction, but they'll wear glasses that have blue light filters in them to try and help with that. Medications that help people sleep are often useful in the short term, but they are really not helpful in the long term. People lose their ability to have the sedating effect of these medications when they're used for a long time. Many people turn to herbal preparations and supplements that they'll get at a health food store to help with sleep issues, and some of those things can be very helpful. But some of those things can also interact with medications that you're taking to treat your cancer or to treat other symptoms and side effects. So it is very important to make sure your caregiving team knows about anything you're taking, even if it didn't come with a prescription from a pharmacy, because those interactions can be significant either in terms of efficacy or to create dangerous side effect interactions that no one wants to have to go through. The other thing to be really thoughtful about is sort of the most obvious thing, perhaps, which is caffeine intake. And we're not always so thoughtful, and we don't always recognize places where caffeine may be slipping into our diet, either in products that we eat and drink, or at times of the day when we may not have realized it. And that can certainly, for people who are sensitive to it, can have an impact on sleep, both the sleep-wake cycle and the amounts of the different phases of sleep, also sleep latency, how long it takes to fall asleep, or sleep maintenance, being able to stay asleep once you've fallen asleep. The sort of flip side to insomnia is fatigue. And I think this is really one of the most vexing symptoms and side effects. I was listening to the workshop that preceded this session in this room about exercise. I think the issues about fatigue and exercise are fascinating and still not well understood. And it was exciting to hear about some of the work that's being done. There are so many factors that enter into issues about fatigue, and it's both physical and psychological, and it can be very hard to tease them apart, to know what's the best way to intervene and try and break the cycle that's related to fatigue. Some of it may be related to treatments that a person is receiving. Some of it may be related to sleep disturbance. Some of it may be related to mood. We often don't recognize how depression can affect sleep, and people can spend lots of time in bed without actually having restorative sleep. And anxiety can affect these things as well, so that people are tired all the time, not necessarily sleepy, but just they feel like I had a patient the other day who said, I just feel like somebody's chasing me all the time, and I just never can sort of recover and get my energy back. There are some medications that we can sometimes use to help people with their energy level. There's variable evidence in terms of how helpful they are. They're often the same medicines that are used to treat attention deficit disorder in children. So they're medicines and in adults too, I guess. But they're medicines in the stimulant category. And while they may help with daytime energy, they may make insomnia worse. So again, it becomes this really delicate balancing act that takes ongoing, continuing communication between somebody who's focused on symptom control and the patient. And sometimes we need collateral information from family members, because we don't always know what our sleep is like. We don't necessarily know how many times we woke up. It can be hard to keep track of how much tossing and turning we're doing, or what the amount of time is. So sometimes family members at home can be really helpful with some of that information, and trying to sort out really what are the best ways to intervene and try and help people get the energy. And some of it is more managing expectations. Sometimes we need to just be kind to ourselves, that sometimes during some kinds of treatments, we need to not expect that we're gonna feel like making a bed or cooking or going to work full time or visiting people or going to worship services in a religious setting, that we may need to just focus on what are the things that are most important when right now my energy is really limited, and making sure that we're doing the things that are the highest priorities, and being able to give ourselves permission to let go some of the things that we don't have the energy for right now, and managing those expectations of ourselves. And so sometimes it's a combination of medications and what we call cognitive behavioral therapy. Mood issues are mostly both depression and anxiety, although depending on whether somebody has steroids as part of their regimen, there can be other symptoms that develop as well. And there are times during this roller coaster of living with metastatic breast cancer that you will feel sad or you will feel worried, and that's normal and not something we should be looking to make go away with a pill. It's something that we should be validating and sharing and helping to live with those times of worry or those times of sadness, because it is an experience that can change your life. And it's okay to feel sometimes sad or worried about those things. The issue is, and when we start to get concerned about it from a medical standpoint, is when that sadness or that worry is so intrusive that it's keeping you from being able to enjoy life and to do the things that are really important to you. And that's really kind of where we start to think that this is not normal thinking through a life-changing situation or an up and down in the course of an illness that's understandable, but something that really needs some intervention. Again, some of the medicines that we use to treat this best don't mix with tamoxifen, and that can really make things complicated and may make it so that a primary care physician or an oncologist or a nurse practitioner may not feel comfortable with prescribing medication for depression or anxiety, because those are the drugs that don't mix with tamoxifen are the drugs that we use most commonly in the first line. And so they may recommend that you see a specialist, a psychiatrist who really has expertise in psychopharmacology in the medications that are used to treat psychiatric problems, not because your depression is so much worse or that, patients say to me, I don't want to go to a psychiatrist, I'm not crazy. No, but this is a situation where the drug interactions really make it so that you need to see somebody who has more expertise than I have, and you deserve to have the most expert treatment possible. And it's, I think, important to understand that that's why we will sometimes call in or recommend that someone see a psychiatrist as a specialist, because of these issues with drug interactions, particularly drugs that are very commonly used to treat metastatic breast cancer. Concentration and memory, which is the clinical way we talk about chemo brain, and also concentration and memory issues that happen not while you're necessarily on chemo. And this is, I think, together with insomnia and fatigue, this sort of very difficult to tease apart set of symptoms that are all so interconnected with each other. If you're not sleeping well, your concentration and attention is going to be poor. Those of you who are parents will remember when your sleep was not well because you were up at night with little babies and your concentration was not good. And it, coupled with being older and having your sleep impaired, whether it's by hot flashes or pain or having to get up frequently to urinate, or any of these other things, can really impact concentration and attention. And so trying to tease together what are the contributing factors and which ones do we need to intervene with that we can be helpful and not creating a new problem at the same time is really important. The exercise talk that was before this talked a lot about exercise as it impacts the cancer progression itself or cancer growth or recurrence. Exercise is something that looks like it can be helpful in terms of attention and concentration. Much of that, I'm reluctant to say much about exercise. I didn't realize I was going to be speaking after an exercise physiologist, but it's a little intimidating. So it may be helpful, it's certainly helpful in people without cancer to improve attention and concentration. And it may be helpful in patients who are receiving different kinds of treatments for metastatic breast cancer. I think it's another area where we don't know as much as we need to know to really make recommendations for patients, but it's also an area where there's little harm likely to come from a moderate exercise program, and certainly in conjunction with discussions with your clinical care team may be something that's worth trying to see if that can be helpful. Food. How could we not talk about food, right? So we see both ends of the spectrum when we're dealing with issues about food in metastatic breast cancer. In most other metastatic cancers, all the focus is on weight loss, unwanted weight loss, particularly of muscle. In women with metastatic breast cancer, we also have issues about unwanted weight gain. And much of that, or weight distribution in the body, that I may have the same number on the scale, but my body is really different than what that number used to look like. And that can be extremely challenging to deal with. We don't do a good job for people who are on the weight loss end of things. We don't do a great job stimulating appetite. That is the other area where medical marijuana tends to come in. There is an FDA-approved medication for stimulating appetite that is THC, the other half of the marijuana, the main chemical in marijuana. It's been shown to be helpful in stimulating appetite in people with AIDS, but it doesn't stimulate appetite in people with metastatic cancer. And we don't know why it works in some situations and doesn't work in the others. And we don't know what implication that means for understanding how that may help stimulate using marijuana in other forms, not just the THC pharmaceutical, in trying to stimulate appetite. So that brings around to sort of closing that part of the loop, which is body image. And I alluded to some of this at the beginning. I think much of the initial thoughts about body image were really about breasts and breast reconstruction, mastectomies, but there are so many other ways in which our bodies change when we are being treated for metastatic breast cancer, and the ways in which that impacts our just sense of who we are as people. And much of that needs to be addressed with managing expectations and cognitive behavioral therapy and support work. It's not something we can fix with a medication, but sometimes it plays out with issues like being hypervigilant. You know, every time I cough, I think I have lung mets. And that's real. That is, I see lots of heads shaking. It's very real. But what do we do with that, especially if we're not talking about living with that for 6 months or a year or two, but living with that kind of hypervigilance and worry for 10 and 15 and 20 years. We need to figure out different strategies to help people manage being in touch with their bodies in ways that are helpful and tuning it out in ways that are not helpful, so that it's not intruding in what's important. And last but not least, certainly not least, are sexual issues. And these are things that many times people like me recognize we are inadequately trained to help you address, but recognize are vitally important to you maintaining your sense of feeling like a person, like not feeling like everything you've always been, who you've always been is not being taken away piece by this disease, and its impact on your relationship with people who you love and who love you. And recognizing that we, as a physician, I was never taught much about this, but I recognize that it's important, tells me that I need to call in somebody who's got more expertise to help with something that has such an important impact on maintaining a healthy, supportive relationship in the personal life of my patient as she or he, together with their partners, are gonna walk through decades of life with metastatic breast cancer. So let's talk very quickly about a couple frequently asked questions. It may preempt some of the questions that you were planning to ask, and if I did that, I'm sorry, but hopefully that will leave some more time for novel questions. And I'll stick around for a few minutes afterwards to answer questions if that'll be helpful. So part of this is really a recap from before. Palliative care is really for anybody who needs relief from pain and symptoms and stress of having a serious illness. That's really sort of a simple level definition of who this is for. And it's for anybody who wants to have the best quality of life they have while they are living with that serious illness. And when is it the right time? That was one of the things over the years I've been doing this. I used to, oh, it's not time for palliative care yet. And I'm like, oh, when is it time to feel as good as you can feel? Like, if not now, when? So it's really based on need in terms of how those symptoms and stressors are impacting the person and their family and their ability to live life. It has nothing to do with how many lines of chemotherapy or immunotherapy or other kinds of treatment you've had, or how long, as best these things can be predicted, somebody thinks you may continue to have your disease. And whether it's disease which can be made to go away and stay away forever, or if it's disease that is going to be in the picture to some degree or another for the rest of your life. And it really has nothing to do with the patient's age. You know, the adolescents, teenagers, older adults, anybody, regardless of their age, it's really about how symptoms and side effects and stressors of the serious illness are impacting the ability to live with it. One of the other things that comes up, and it's gotten a lot of attention, and I think it's really important, is that in some illnesses we have shown, and the most notable of which is metastatic lung cancer, we have shown that palliative care together with disease-directed therapy actually results in longer survival. We don't know that to be the case for metastatic breast cancer yet because the studies have not been completed and published, but there is reason to believe that if anything, it's neutral in terms of survival time, but it may actually be beneficial. Palliative care is provided by an interdisciplinary team. The availability and makeup of those interdisciplinary teams varies a lot as the field grows and the specialty changes. There are more and more interdisciplinary palliative care teams available to people getting treatment in outpatient cancer centers. It's very readily available in the inpatient setting, but as we're trying to follow those aspirational best practice guidelines from the American Society of Clinical Oncology, we are trying to make it more available in the outpatient setting and earlier on in the course of disease, not only for people who are having serious enough complications that they have to be hospitalized. So, last frequently asked question is, so how do I get this? Sounds good. This sounds like it might be helpful to me. Is it available to me in my center? How can I find out? So that's where getpalliative.org, which is the patient-facing website for the Center to Advance Palliative Care, is available. It has listings that you can find out about palliative care resources in your community, in your treatment network, and also has some information that patients have found very helpful and families have found very helpful, opening conversations about palliative care up when they think it would be helpful to them, and they may not have shared all of the ways in which they're really struggling with some of the side effects and stressors and symptoms related to their disease and its treatment with their cancer care team, and how they can raise those issues in a way that will facilitate bringing palliative care teams on board. So that would be one of the resources that I would recommend to get information. The American Academy of Hospice and Palliative Care, which is palliative medicine, which is the professional society for palliative care physicians, also has information on what's available in your community. Getpalliativecare.org has a really comprehensive list, and those are certainly important places where you can look. And I think we will move on to questions from our live stream and live audience.
Great, thank you so much, Dr. Popp. So we only have 7 or 8 minutes for questions, so we'll go quickly. Is managing lymphedema part of palliative care, and if so, how is that dealt with?
Great question. So the mainstays of lymphedema treatment are using complete decongestive therapy, as well as addressing the pain that can come with it. So we do that work. We do it in conjunction with physical therapists and occupational therapists that are experts in that disease. And we will also, again, often work with continued home use of decongestive therapy so that people can continue to have maintenance of alleviation of their lymphedema symptoms at home, as well as careful monitoring for infection and skin condition, making sure the skin remains in good shape to minimize chances of infection.
Great, thank you. And another question that we got is, what is the difference between integrative care and palliative care?
Oh, so that's an excellent question. Integrative care tends to be a term that's used for things that are often also considered alternative medicine, but rather than being, massage, Reiki, acupuncture are a few things that I can think of. So those things, when they're used as an alternative to conventional medical care, get referred to as alternative medicine. When they're used in conjunction with conventional medical care, it'll be referred to as integrative medicine. So we will sometimes, if we have access to those treatments, we'll use those as a palliative care team. In the center where I work, we actually have acupuncture available, for example. It's the first place I've worked now that's had it over these years. So we can sometimes use some of those therapies. A lot of it depends on what's accessible in the center where you're receiving treatment.
Our next question is, are chronic urinary tract infections often seen in metastatic breast cancer, and how do you treat it when it's chronic?
So that's an interesting question. By itself, that's not a symptom that I've seen a lot in my patients. I think it can sometimes be seen as a sort of secondary symptom related to some of the hormonal changes affecting the reproductive tract and the urinary system as a result. And it could certainly, I could see how it could predispose a person to urinary tract infections.
Thank you. Our next question is, could you expand on the concerns with the use of benzodiazepines?
Oh, yeah, that was a point on the slides that I didn't emphasize so much. So benzodiazepines are a class of medications that have traditionally been used to treat anxiety. They're also often used as part of the anti-nausea cocktail that is administered before many chemotherapy medications. And benzodiazepines, together with the opioid medicines, we're increasingly recognized are a combination that has significant increased risk. And so we are trying really hard not to have those medications being used in conjunction, and if so, making sure people are aware and prepared for the potential risk of either an accidental overdose or a bad drug interaction. We also used to use benzodiazepines as sort of the first line anti-anxiety medication in the past. We now have much better anti-anxiety medications which are safer to use in the long term. So we try not to use benzodiazepines for most people as a long-term anti-anxiety medication.
Thanks for sharing more about that. We got a couple of questions about that. And sort of as a follow-up, you talk quite a bit about CBD, and one person is asking, can it be used for anxiety and depression?
So the short answer is we don't have the research to know very well. To the degree that we understand about the chemicals that make up the marijuana plant, we think that the other elements, the THC elements rather than the CBD elements, are responsible for the relaxing effects and what we call the psychogenic effects of that. So we think it's more the other chemicals and not so much the CBD, but we don't have good research, so we don't know.
Thanks, Dr. Popp. This next question is about opioids, and one of the people watching says that that they've been taking opioids for 3 years for pain for metastatic disease and very difficult side effects, and has had to switch opioids. Knows that they're addicted even though they're taking the drugs as prescribed, and feels a lot of shame, and wonders how you talk to your patients who are struggling with these sorts of issues.
That is a great question, and it's a very timely topic. I think I know in my own practice, I have had to learn a lot over the years as what we've understood about opioids has changed. And I've had to learn a lot about the psychology of substance use disorder and substance dependence that I didn't know 20 and 30 years ago, both how to talk to people about it and understanding issues like the shame and other negative emotions that people can feel. And I think it really takes talking with a lot of sensitivity and without judgment in order to try and get a good understanding about what's going on. And if someone wants to stop taking those medicines and feels that they don't need them for pain anymore, how to help them get the appropriate kind of help. And there is excellent help in that situation. But I think, learning what the local resources are and helping in a supportive way someone access that while continuing to treat them for their other symptoms and side effects is really important.
Thanks for addressing that question. So I'm going to give one last question, and I'll come up and quickly do some closing remarks. Dr. Popp, do palliative care teams address, quote unquote, outside issues that we deal with, such as having a child with special needs or other situations that are made worse or exacerbated by the chronic aspects of living with metastatic breast cancer?
That is an outstanding question, and I'm glad you included that as got in there. Absolutely. Part of the reason and the value of the interdisciplinary team in addressing the needs of patients living with cancer is making sure that we address everything that's impacting it. So I have had referrals recently for someone who had a child with special needs and needed to make sure there was a plan in place for how that child was going to get care on the chance that they had a treatment complication and needed to be admitted to the hospital. Or looking for the longer term, they had never made long-term plans for their child's needs. People have situations where child custody is an issue and they haven't addressed them, and they need to be. So, and there are other social determinants of health issues about housing situations, about food insecurity, a whole host of issues that absolutely impact someone's ability. The bandwidth that you're using to address some of those things can wind up being bandwidth that you don't have to address the more disease-specific areas. So we have to look at all of those things because they all have a significant impact. So thank you very much for your attention. And after the closing remarks, if anybody has any specific questions, I'll be happy to stay around for a few more minutes.
Thank you so much, Dr. Popp. Let's give her one more hand. She really covered a lot in a very short amount of time. So thank you so much. It's hard to believe that we're at the end of the 2019 Living Beyond Breast Cancer Conference on Metastatic Breast Cancer. It's gone really fast, hasn't it? So we're at the end of our programming, both here in Philadelphia and on our live stream. And I just wanted to say a couple of things to send you away with, some housekeeping items. First of all, I know you've heard this a million times, but we'll be sending out evaluations right after this program. We read every single one of them. If you fill it out, you get a chance to win a $50 gift card. So please take advantage of us and let us know what you thought. For those of you in the room who received travel grants, the travel grant checks will be given out starting at 12:15. And then just a couple of thanks for some folks. We want to, again, thank our sponsors, both the corporations and the many individuals who make all of our programs possible. I'd like to thank our board members and volunteers who have been here all weekend, and I would especially like to thank our staff who work all year to bring this conference to you. None of them are in the room because they're all working, but I do want to thank them publicly. So we know that we have given you a lot to think about and process over this weekend, that you've sort of been here, whether you're on the live stream with us, whether you're in the room in this bubble of safety, and now you're going back out into the world. And what I'd like to say is that Living Beyond Breast Cancer is still here for you after today. If you go to lbbc.org, you'll see an area that says, I am living with metastatic breast cancer. Click on that, and it'll take you to everything that we do throughout the year, which includes webinars, brochures, other live stream programs where you can participate, text with us, interact with us, and we can support you. And you can always contact our helpline to talk to another person who's living with metastatic breast cancer. And I hope that you'll take advantage of all of those programs throughout the year. And we look forward to seeing you again in 2020. Thanks for joining us.